to the 5th Campus Conversation of the year. The goal of the Campus Conversation series is to have faculty and students and staff engage with each other about some of the big issues of our time going on now and affecting all of us. As a community dedicated to social justice and diversity, we come together to try to understand current events and talk about these issues. Today, the topic is, what are Chicago's health disparities and why does it matter? We are privileged to have with us today a distinguished and truly expert panel of faculty and administrators from UIC to discuss this topic. We will begin with Professor Amanda Lewis, whom I will introduce in a moment, to provide some background, and this will be followed by short presentations by our panelists, the Dean of the School of Public Health, Dr. Wayne Giles, the Associate Vice Chancellor and Director of the Cancer Center, Dr. Robert Winn, and Professor Angela Odoms-Young from the Department of Kinesiology and Nutrition. They will then have a discussion among themselves, and then we will open it up for Q&A from the audience. And paper has been provided on your seats with a pencil so that you can write down your questions. We will collect these questions and give them to the panelists around 1 o'clock, after about an hour of their presentations and conversation. It's now my privilege to introduce Dr. Amanda Lewis. Dr. Lewis is a professor of African American Studies and Sociology and the director of the Institute for Research on Race and Public Policy, also known as IRRPP. The IRRPP was created in the 1990s and has as its mission to increase society's understanding of the root causes of racial and ethnic inequality and to provide the public, organizers, practitioners, and policymakers with research-based policy solutions. In May of 2017, the IRRPP, under Amanda Lewis's direction, published a report titled A Tale of Three Cities, the State of Racial Justice in Chicago. This report examines the changing conditions of Chicago's 3 largest racial and ethnic groups, Blacks, Latinx, and whites, over the last half-century. It finds that ethnic and racial inequities in Chicago remain strongly embedded in the city today across the board, but particularly in the areas of education, economics, justice, and health. And health is the topic of today's campus conversation. The report offers accessible data and analysis, providing an excellent resource for further research and policy solutions. I have read it. I have shared it with many, including members of the Obama Foundation. In fact, just this morning, I wanted to look at it while working on these remarks and realized that I don't have it anymore. I've given away all my copies, even though Amanda keeps restocking my office. So we need another restocking, Amanda. But the IRRPP isn't all that Dr. Lewis spends her time on. She's also an accomplished scholar whose research focuses on how race shapes educational opportunities and how our ideas about race get negotiated in everyday life. She's a perfect example, actually, of engaged research here. She just told me she's on her way out to Oak Park to talk at a school after this. Her research has appeared in many academic journals, and she's the author of the books Race in the Schoolyard, Negotiating the Color Line in Classrooms and Communities, and the book Despite the Best Intentions, Why Racial Inequality Persists in Good Schools. She's the co-author of Challenging Racism in Higher Education, Promoting Justice, and co-editor of The Changing Terrain of Race and Ethnicity. So please join me in welcoming Dr. Lewis, who will provide more detailed introductions of our panelists. Thank you.
Here you go, Susan. I'll give it to you at the end. There's one right there. Yes, absolutely. I am going to keep my remarks short, partly because this is a panel on health, and you probably gleaned from Susan's comments that I am not a health expert. So, but I do have a few things I want to say just to get us started. At the Institute for Research in Race and Public Policy, one of our central aims is to increase knowledge about the experiences and conditions of racial and ethnic groups nationally but especially locally in the city of Chicago. We're interested in capturing the complicated truths about dynamics in our city today, and in part undertook the writing of the report Susan was talking about out of our own frustration with popular narratives about Chicago today. This captures some of them. As many of you probably experienced, if you travel outside the city, people, and you tell people you're from Chicago, they often ask if you're okay, is everything, you're worried. We knew that the realities of Chicago's daily lives were far more complex than the picture of supposedly violent communities described in national news stories. In every neighborhood, we find families living and thriving, hardworking young people trudging to school, parks filled with residents walking, playing, exercising. We find communities full of immigrants working overtime to make ends meet. And yet we also knew that even as the Chicagoans of all racial and ethnic groups want to live in safe and healthy communities, not all have equal access. We named our report A Tale of Three Cities because there really isn't one Chicago experience today. There are several. In the report, we primarily discussed the conditions of Chicago's three largest racial and ethnic groups, African Americans, whites, and Latinxes. And I'm happy to say, however, that we are nearing completion of a new report on Asian Americans in Chicago, which we'll be releasing next month. The central finding in this report is that racial and ethnic inequalities in the city of Chicago remain pervasive, persistent, and consequential. These inequities affect the lives of Chicagoans in every neighborhood. They have not just spatial but also deep historic roots and are embedded in our social institutions, and they have powerful effects on the lived experiences and opportunities of all Chicagoans. Facing this truth is for us a key step of addressing this reality. As Baldwin put it, not everything that is faced can be changed, but nothing can be changed until it is faced. So we are faced with the reality that many Chicagoans continue to struggle not only with the long-term effects of structural racism, but ongoing patterns of discrimination. Along with other inequities, just to keep you on your seats, health disparities between groups in Chicago are also vast and consequential. Yet as much as health disparities data tells us important information about dimensions of disease and adverse health conditions between groups, we are still working to understand how and exactly why race matters so much for health outcomes, how they are related to racial and ethnic differences in access to medical care, in facilities, inequality of treatment within medical settings, our experiences with medical personnel, our level of stress, the safety of our communities, the amount of toxins in our air and water, how much we have to pay for health clubs or organic food, et cetera, et cetera. And in this way, health outcomes for Chicago residents are deeply connected to other aspects of racial and ethnic inequality. Two other points I want to make, and then I'm just going to share a couple quick data points. Despite what you read about in the national news, one of the other big conclusions of our report is that far more Chicagoans are impacted every day by the effects of structural violence than by the impact of interpersonal violence. This is actually one of the key themes of the new Center for Health Equity Research here. Did I get that right? Yeah, okay, good. Which is going to be a major important partner on campus to really advance this conversation. This framework is similar to what Beth Ritchie talks about in her book Arrested Justice as the violence matrix. It reminds us that interpersonal violence is only one small part of a larger set of relations that do harm. The long history of structural racism puts many in harm's way and has lots of different health consequences on multiple levels. It's about how race gets into our bodies and also about how racial dynamics mediate collective access to wellness. Okay, I just want to share a couple quick data points and I'll make connections and then we're gonna move it on. The report, the Chicago Sun-Times headline about the report said it was lengthy. Said lengthy report, which I think is true. It's 180 pages. It weighs a lot if you want to borrow one. But so I'm only hitting a few key points on the report. But one of the things I want to point out here is this is about unemployment rates. Many of us know that for a long time there have been major gaps in unemployment rates across groups. On average, Black and Latino unemployment rates are at least 2 to 3 times white unemployment rates, and that has been true for decades. I think one of the important points about looking at a piece of data like this, though, is that at that point in the U.S. when we were most recently in a national crisis about our economy, when we said that things were bad, when we recognized we were in recession, white unemployment rates were at 8%. that unemployment rate is lower than it has been for African Americans or Latinos any time over the last 40 years, right? So what is a crisis for some groups is actually good news for others, right? Important to keep in mind and has lots of different ramifications. One other way of looking at this, so Latino unemployment rates are a little bit lower than African American unemployment rates in the city, but if we look at what kinds of jobs people are working in, what kinds of salaries they're making for those jobs, we see, for instance, here that a majority of Latinos in the city are making less than $15 an hour, which we would sort of talk about as an important marker of whether people are earning a living wage. And in fact, higher percentages of Black and Latino workers are making less than $15 an hour today than was true in the year 2000. So lots of people working, but not necessarily making a living wage. Unemployment, employment data, income data often underestimate the kind of levels of inequity between households. One of the things we often talk about is the importance of paying attention to wealth differences. Wealth is in many ways the congealed effects of these long histories of racism in our policies and practices. And as you can see here, not only are those gaps huge, but they've actually gotten worse as a result of the recession in the last 10 years. So Black and Latino households have on average 1/18th to 1/20th the wealth of white households. This is national data. We didn't have great data to look dive into this in the city of Chicago. What we did have data on is households who have zero or negative net worth. And you can see here the numbers are about 1/3 for Black and Latino households, about 15% for white households. And I can't emphasize enough how important this measure is. So this is basically a measure of whether you have any safety net in your household at all, for any little hiccup that might come along the way. And it could be even something like getting a flat tire, getting in a minor accident, or as I had to last week, going to the pharmacy and picking up medicine for your kid to find out it was $200, right? Do you have the liquid assets in your household to weather any of these issues? And the answer for many and far too many households in the city is no. Okay. I want to mention this just for one reason. We talk about the mass imprisonment and imprisonment rates, and there's a long section of the report. We talk about imprisonment rates in the state of Illinois. We have the most overcrowded prisons in the country. We have imprisonment rates that have been going up exponentially, and they are in fact not at all correlated with crime rates, which are at their lowest point in 30 years. Part of the reason why this data is important, however, is also just to think about resources and where we're spending money in the state. And if we look at where spending has gone over the past several decades, direct expenditures on criminal justice in the state, that's on corrections, police, and the judiciary, have gone up dramatically, whereas we think about lots of other domains, some of those directly related to health, spending has gone down, partly related. So broadly, reducing health disparities will require, in many ways, turning our attention within and beyond the health domain, beyond individual decision-making or behavior, to the context and constraints of those choices, as well as to the availability of resources and opportunities for health. The reverberations of our collective racial history, along with persistent patterns of racism today, yield stark patterns of inequity we cannot ignore. And I look forward to talking to my fellow panelists about all the important work going on to try to address some of these patterns. Now, it is my great pleasure to be able to introduce three wonderful colleagues here on campus. I'm going to not read their entire bios, as that would take us all the way till 1 o'clock. So I'll give you some of the highlights, and we're going to go in reverse alphabetical order. So starting with Dr. Wynn. Dr. Wynn is professor, and associate chancellor for community-based practice, and director of the University of Illinois Cancer Center. He is a professor of medicine at the U of I Chicago, Division of Pulmonary Critical Care, Sleep and Allergy. He also received his medical degree from the University of Michigan Medical School in Ann Arbor. As Associate Vice Chancellor for Community-Based Practice, Dr. Wynn is responsible for the management of the UI Health Mile Square Health Center, a 13-site federally qualified health center network. The goal of community-based practice at UI Health is to integrate and coordinate healthcare and the surrounding communities, build a 21st century model of community-based healthcare providers linked to the mission of our academic health center, and develop meaningful research programs that can be integrated into the community. As the director of the UI Health Cancer Center, Dr. Wynn has implemented the first comprehensive community-based cancer center. From bench to community, he has made great strides to enforce an evidence-based community approach to reduce the burden of cancer. Dr. Angela Odoms-Young is an associate professor of kinesiology and nutrition and Institute for Health Research and Policy fellow. Her research is focused on understanding social, cultural, and environmental determinants of dietary behaviors and diet-related diseases in low-income and minority populations. Her current projects include studies to evaluate the impact of the new WIC food package on dietary intake, weight status, and chronic disease risk in 2- to 3-year-old low-income children and vendor participation, identify strategies to improve program participation and retention among WIC-eligible children, evaluate the efficacy of a community-based participatory weight loss intervention in African American women, and examine community engagement approaches to food justice. She serves on the executive committee of the Consortium to Lower Obesity in Chicago Children, which awarded her the 2015 Catherine Kaufer Christoffel Founders Award. And finally, one of our newest colleagues, Dr. Wayne Giles, is the Dean of the UIC School of Public Health. Dr. Giles joined the Centers for Disease Control and Prevention in July 1992. He's currently, must be an old bio because it say you're currently the director of he was the director of the Division for Heart Disease and Stroke Prevention before coming to UIC. He holds a BA from Washington University, a master's from the University of Maryland, and a doctorate from a medical degree from Washington University, as completed residencies in both internal medicine and preventative medicine. His past work experience included studies examining the prevalence of hypertension in Africa, clinical trials evaluating the effectiveness of cholesterol-lowering agents, and studies examining racial differences in the incidence of stroke. We are very happy to have him here on campus with us. So each of them will come up and present, and then we'll sit down and have a little bit of conversation and then open it up for questions. Thanks. Will you do the switching?
So I think for those of you who know me, I was actually given the memo to keep this under 10, and I will. The original was 5, so I'm going to see what I can do. I get really passionate around these things because the reality is I think we have had these discussions around health disparities for a very long time. In fact, some of the conversations are almost like a good old pair of shoes. You remember it when, and when you put them back on, oh yeah, right. These have been going on in some cases for 30 to 40, in some cases 50 years. And interestingly enough, I would never tell you that there has been no progress made, but I will tell you that we still have to recognize that where we ought to be is where we're not. I throw up this first slide simply because many of you see this. This is like an old record that I will play for some of the people who know what records are. There's a couple young faces, but I've been teaching my 18-year-old son about the beauty of records. But anyways, we used to actually sort of say, you've played the groove out in that record because you've played it so many times. I am unapologetic about this slide and many of the things that I'm going to talk about because, again, we have many of the people in this room have been on the front lines for 30, 20, 40 years dealing with the same issue about the disparities. Interesting enough, when I read the newspaper, and sometimes when I go to the barbershops, it's amazing the conversations that we think people don't have in those beauty shops and in barbershops around the new technology. Now, the crazy thing is, it's not lost on me that the Loop certainly, right now with a life expectancy of 85 and West Garfield Park with 69 when you round up, and many other areas in the Chicago area, we have this disparities, and yet we're sitting on the 21st century with the largest promise of technology, the biggest promise of cures. And interestingly enough, rarely in our conversations, other than in a select small group, are we actually talking about what I think is the largest sort of issue, the implementation of this into our communities and the benefit of our communities. We are amazed as academics about framing the question, but what I'd like to do is to challenge us to go beyond framing the questions and talking about and chasing academic excellence and actually having something and pushing us to a direction of academic relevance where not only do our papers and our grants count, but the impact in the community, the measured impact in the community also counts for the job we're doing. That, to me, seems to be a nice challenge for the 21st century. And I understand that many people would say, well, that's hard to do. But interesting enough, when it comes to other hard things, putting a man on the moon, coming up with computers, now coming up with ultrasounds that can be measured on your phone, you can actually take your iPhone, put a transducer on it for a quick $2,000 and be able to diagnose your own kidney stone. And yet, every article in Newsweek talks about the promise of big data, the promise of big science, the promise of all this, and yet, when I tend to go into these shops, they're talking about, well, when is our time, and when will this actually happen for us? So I'll tell you what my biggest fear is, and it's not that the disparities exist, because that's a given. My biggest fear is that these new technologies and these new cures, checkpoint inhibitors, immunotherapies, and all these other things are actually going to work. They're going to work so well that the unintended consequence may be that we definitely improves the lives of some, but not all. And again, what keeps me up at night is that we'll have the loop at 90 or maybe 92 in the next 7 years. And Garfield Park, based on what's actually happening right now, particularly some of the political issues and some of the programs that may be undone, may not actually even be at 69 as we look over time. Our issue is one of urgency. If I had to leave 3 points, and again, I'm going to wrap this up because this is new practice for me getting done under 10 minutes, because sometimes when the spirit moves, anyways, but the spirit has told me 10, so we're going to keep it under 10. But there are 3 points I want to make. The first is that we're certainly having conversations, but I want to say we should be adding new conversations, and that is we are frequently not in those discussions, for example, of AI. In fact, all of us sit and we sort of say, oh, the future's here, this is artificial intelligence, oh, machine learning. That is crazy for us to go to sleep on. The truth of the matter is, by not being part of that conversation, we run the risk of having unintended consequence of gender and racial bias into machines that will be difficult to argue their racism. And yet we stand as if it matters not that, well, that's those engineering people in Silicon Valley. We have quick examples of that. Many people know that there is a famous case out of North Point. North Point was in Silicon Valley, which helped to help our judges reduce the number of people in jail. We would pick out the good people who wouldn't do any crime, and those ones who were predicted to do crimes and predicted analytics would stay. This is no surprise, so I'll just give you the punchline. Interesting enough, that predictive analytics actually sort of said that if you were African American, you were 2.5 times more likely, actually 3.5 times more likely to commit a new crime, as opposed to if you're Caucasian. Again, abbreviated. Interesting enough, when they went back and looked at the data, it was all wrong. When they asked the company, well, wait a minute, it's wrong, they said 2 things that actually made me laugh but wasn't so funny. 1, well, machines can't be racist. And 2, well, well, what do you want, right? We're not wrong, right? It turns out that data is nothing but humans putting together algorithms that then imparts that into machines. So as we're comfortable with the concept of machine learning, I just want to put that out there, that all of us should be interested in artificial intelligence, deep learning, and machine learning, because it's going to be a part of your life whether you want it or not. They talk about Plymouth Rock landing on you. Well, you're not landing on Plymouth Rock. Plymouth Rock has just landed on us. We just haven't had the ouch factor yet. It's like the Three Stooges where you get smacked and 3 minutes later you go, ow, well, we're there. 2, in addition to actually having these kinds of conversations about this new technology, I will implore us to actually take another step back about our community connectedness. In some ways, I believe we are existing in spheres that we're well-meaning and we're doing all these wonderful things, but it's loose connective tissue, because the question is, are we really connected in meaningful ways to our community? And not just because we say we are, but what's the real form in figuring out how we really are connected to the community? The truth of the matter is, frequently I walk around some of our FQHCs and I ask people about not only UIC, but all these other things about what's actually happening, and the answer is, oh, I didn't know that. Not good as we approach the 21st century. And the last thing I'm going to leave you with, and again, I know I'm not supposed to say it, but I'm going to say it anyways, and that is, I think we are at the very verge, we are on the very moment where, believe it or not, people are really looking to public institutions probably to drive the way. And I'll give you an example. I was just in a meeting with a bunch of cancer center directors, and it was the craziest meeting. They were sitting and saying, we have some of the most outstanding cancer centers, and they're directly in African-American neighborhoods, but if you look at where the cancer centers are and the access to these African-Americans to those cancer centers, it's zero. In fact, I had a cancer center, and I'm not going to call them out, but they're in a place where I've been a lot. And they said, well, it's tough to get African-Americans here. And then you started analyzing that and go, because of the insurance. I'm proud to be part of a public institution that Lincoln put together that said we're not just a public university, we're the public's university. And I actually think that in that room, someone stood up and said, this seems incorrect and wrong. Why are we paying for all these cancer centers that are creating all these new things, but none of it's actually getting to the communities they live in? And in fact, someone stood up and said, but I think we have a cancer center director back there who actually has this thing about bench the community. Could you tell us a little bit more about that? It is time to talk about genes to society. It is not siloed, it is all connected, and whether you do community work, basic science work, or whatever, it is time for us to get together, and I believe our rightful place is to not follow what the patterns are, but to create them, and I believe we're going to create them here. So that was under 10. So whatever said.
Okay, I'm going to try to stay under 10 minutes. But I wanted to, and of course, Dr. Wynn is always a hard act to follow. Can you hear me? Yes. I'm getting some feedback with this. But I wanted to talk a little bit, kind of to elaborate on some of the things that were pointed out in the report, to look at root causes of these health inequities. And I also wanted to mention that in addition to my other affiliation, I work in the Office of Community Engagement and Neighborhood Health Partnerships, which was previously directed by Dr. Cynthia Boyd and now under the leadership of Angela Ellison. So I think that there was three really takeaways, as was mentioned in the report, that I wanted to highlight and also talk about some work that's being done on the south side of Chicago that's grassroots. I think, as Amanda mentioned, we always go places. I've been to Orlando this week. I was at Hopkins. And of course, when you say Chicago, people do come up to you and they say, you know, basically, are you running for your life? Not looking at some of the assets. So I want to highlight some of the assets in a project that's coming directly from the community to address these inequities. I think the first point is really key, and of course you can take a look at the report, that inequalities between blacks and whites are either stagnant or widening. I think that is a really important point, because when we look at the dollars that have been spent in the years that we've been doing disparities research, I started graduate school in the 80s, and I still feel like, or late 80s, I still feel like we're having this same conversation, and when I talk to some of the elders in my community, they really feel like they're having the same conversation. The healthcare providers, pharmacies, my work is focused on obesity and food access. We know that racial segregation plays a role, and that birth to on that these disparities persist. I think that's really key. So traditionally in health, and particularly in nutrition, we've looked at behavioral causes of disease, tobacco use, diet and physical activity, BMI. But really, when we look at those root causes, social and economic factors play the most important role. And if you look at even these other root causes that exist, if we look at and we talk about health behaviors, they really are at the root of health behaviors as well. There was a really good report that came out, and this may be difficult to see, a National Academy of Science report that really highlights when we talk about disparities in Chicago or inequity in Chicago, that it's historical, political factors, and it persists over the life course. And I think that this diagram is really an important one. It's the systemic level, so when we talk about immigration policies, incarceration policies, predatory banking, community level, differential resource allocation, racially and class segregated schools. So it's multiple levels. Institutional level, also avert discrimination and implicit bias, and then interpersonal level, because institutionalized racism, stereotype threat, and embodied inequalities are really important. So a lot of times, and I can give an example, we talk about food deserts, but the biggest inequality when you look at food access of African Americans started in slavery. So we talk about things as they're being very recent, but we know that they have persisted over 400 years plus. So the goal is, when we look at solutions, is to move upstream to have population impact. We have refined our technique in counseling and education, or I should say not refined, but given a lot of emphasis on counseling, education, clinical interventions, but less so on population-based strategies, really to change the context of healthy decision-making or deal with things like structural racism, socioeconomic disparities, and inequity. So really what we need to do is think about interventions to go upstream, further upstream. And I want to give an example of that in Imani Village. Imani Village is a sustainable, eco-friendly, mixed-use, green, intergenerational community with a village environment committed to lifelong education, health, and economic development. Imani Village is a project that's being developed at 95th and Cottage Grove by Trinity United Church of Christ. And Trinity United Church of Christ started an LLC called the Trinity 95th Cottage Grove Planned Community Development to develop 30 acres that was purchased at 95th and Cottage Grove into a village called Imani Village that restores and supports residents as well as impacts the surrounding community. Trinity is under the leadership of Otis Moss III and is one of the largest congregations in UCC and has over 70 active members. So why Imani Village? And I may skip this based on time, but as was mentioned, in addition to Chicago overall, the area surrounding Imani Village is also, you see the disparities, health inequity at work. When you look at social needs, when you look at hospitalizations due to hypertension, hospitalizations due to diabetes. So the purpose of Imani Village is really to look at those areas that are consistent with community level health and wellness. So in a community, if you think about communities that support people, you have access to recreation and open space, access to healthy food, access to medical services, access to public transit and active transportation, access to quality and affordable housing, economic opportunity, complete list of neighborhoods, safe in neighborhoods and public spaces, environmental quality, and green and sustainable development and practices. So this is Imani Village. This is the site plan. Advocate Medical Group is a partner, and they're developing a health center at Imani Village that will be open in December of this year or January of 2019. There's a housing partner to look at affordable housing. I'm working specifically on the Urban Ag and Food Hub, where we're developing, there's a 30,000 square foot building on the site of Imani Village that we're developing into both Food Hub, where you have the back of the house, as well as healthy food retail, in a partnership with the Nature Conservancy to look at overall sustainability and conservation. So I think the common theme of Imani Village as one example is also what we need to look at when we redesign communities to be supportive of health. A living, healthy, green, educated, empowered, and inspired and whole. So really, we think about policies, we think about statistics, but I still remain in Roseland. I still live on the south side. I'm not leaving the south side. So when you look at it, when I talk to my neighbors, it's about the data, as Dr. Wynn suggested, but behind the data are people. And so we want to make sure that people live as whole human beings and that they are supported. So thank you.
Good afternoon, and it's a pleasure to be here today. And I don't have any slides, because I'm just going to talk for about 5 or 10 minutes about some of my experiences. And as was mentioned, I'm new to Chicago. I've been here about 5 or 6 months, but as the other presenters, probably the first thing that I heard people said when they heard I was leaving Atlanta, they said, oh gosh, the weather. How are you going to survive the weather, number one? And number two, they talked about the violence that's going on in the city of Chicago. And I think there are a couple of key themes that I want to mention. And I think as you look at the report, you can look and see higher rates of heart disease and diabetes and cancer. Amanda talked about what was going on in terms of violence as part of the work as well. But we also need to remember and think about sort of what's happening, what I would say, above the neck. What's happening in terms of mental health issues, what's happening in terms of depression and anxiety, because we also need to remember that what happens above the neck is very connected to what happens below the neck. So I think thinking about mental health consequences is going to be important. And I'll weave some of this back in just a minute. The other thing we got to think about is disability. And it's not just about death, but it's about people who become disabled from these chronic conditions, from mental health and other things that are going to happen. And then when you look at these communities, whether we're looking at violence, cancer, diabetes, obesity, et cetera, right, we're seeing the same communities over and over and over again. And I think what you've got to begin thinking about is what's causing that. And I think it goes back to what we think about in terms of the root causes that may be causing that. And I think part of that is the social determinants of health, but I also think part of this is the role that stress can play and the activation of the pituitary, hypothalamus pituitary adrenal axis that can cause this, and the secretion of corticosteroids that can occur, epinephrine and adrenaline that can occur because of that, and the impact that stress can have. I will tell you that a couple of weeks ago, as Amanda mentioned, I finished residencies in preventive medicine and internal medicine. And a couple of nights ago, I was driving home up on the north side from a faculty member's home from the dinner. And I saw blue flashing lights as I was driving home. And I can remember saying, okay, Wayne, where are your hands on the steering wheel? I can remember the hair on the back of my neck perking up a little bit. My heart was racing a little bit because what happens if this policeman pulls me over, right? It's that impact. What happens when you have groups of people that are going day to day thinking that way? What is the impact that can have on an individual? And that happens to someone who's had, 15 years or so of education beyond that. So thinking about that impact and those stresses. And we don't do a good job in our epi work of measuring those types of impact, but those are huge impacts as we move forward. The other thing that I think is important as we think about this, right, in our studies, we tend to lump people together, right? So we talk about African Americans, we talk about the Latino community, but the reality is we need to be much more precise. Not all Latinos are going to have all the same, not all African Americans are going to have the same experience. And we need to be more precise. We talk about precision medicine. We should be talking about really precision public health as well. We need to be much more precise. The last thing I want to mention is this is not new. This year marks the 150th anniversary of the birth of W.E.B. Du Bois. He published in 1899 a book called The Philadelphia Negro. This was the first time anybody did a systematic review of the health status of a community of color. In that document, he talked about housing, he talked about poverty, he talked about incarceration, he talked about racism. We've been talking about these issues for 119 years. The other thing that I think is important, 50 years ago, I know, actually, I think it was last week or the week before, there was a celebration about the Kerner Commission report. That report said that we are moving to two societies, one black, one white, separate and unequal. Very similar to what we have in the report that IRPP released. In 1985, Ronald Reagan's Secretary Heckler released the Secretary's Task Force on Black and Minority Health, 1985. Again, talking about health disparities, talked about impacts of racism. In 2002, the Institute of Medicine released a report on unequal treatment, confronting racial and ethnic disparities in health. And now we have yet another report. My question for you as I conclude is, how many more reports are we going to write? I have a few key questions for you to think about. What is UIC going to do? What are our schools and programs going to do about it? And finally, what are you going to do about it? Thank you very much.
I'm going to start us off just with a question, just to get the conversation going, and then we will open it up to the audience. And that was actually a perfect transition, because one of the things I'd love for each of you to begin by talking a little about is what, and this is launches beautifully off of something that Dr. Wynn said, which is, if we think about UIC as the public's university, I do want to think from each of the places you're situated, what is UIC's role in beginning to think about what are we doing currently, what are the most exciting things you've seen on campus about making an impact in the city around these health disparities? Who wants to start? You first.
Actually, I'm excited. I think that unlike most other universities within the city, we have things that we have special that we may overlook, but let's stop that. First of all, the 7 health colleges being in one center is something that's amazing. The only thing we have to do is figure out better how to talk to one another. I figure this is just mostly an issue about communication than anything else. We have an East and a West campus. So we cover the gamut. And so the truth of the matter is, if, I've always liked, back in the day, ACT UP, right? Mm-hmm. Yeah, because the name at the end of it is to unleash power, right? I mean, I think that we at the end of the day have an ability to unleash a type of power and effect that other institutions within the city would like to do, but we can't. It's just a matter of mostly communication. I think back to our mission of having an elevator school, and that many schools, when I actually go to Inglewood, I go to my FQHC, I'm not only taking care of patients within Inglewood, but I'm also looking in the community and sort of saying, you know what? you should be thinking about coming here, right? So I think that unlike anybody else, we are well positioned to literally have major impact and lead with the community. But the days of doing things for the community should be over. We should be doing things with the community, right? And with the community guidance. And I think if we can have that secret sauce about better communication on campus, communicating with our communities, I swear to goodness, you look back 10 or 15 years, it'll be not only fun, but we'll hopefully be able to see our impact.
I think within the School of Public Health, there are a couple of things we've done relatively recently. One is we started this year on Thursday evenings a course called the Epidemics of Injustice, which got started through a group called Radical Public Health. But there we've got conversations going on about labor issues, reproductive health issues, disability issues. So I think that provides a really nice opportunity for students and faculty and community members collectively to have conversations about sort of racial and ethnic health disparities and other health disparities that are going on and sort of opportunities to take action. The other thing is Policy Link, for those of you who know, will be actually April 11th through the 13th having their conference on health equity and health disparities here in Chicago, and we'll be sending a delegation there as well. But I think it will provide a nice opportunity also from additional discussion around some of these issues as well.
Yeah, I can just, this is on. Speak briefly about too, and I know Dr. Wynn didn't mention SHARE, which I think is an excellent initiative to look at structural violence and to look at science, you know, the traditional research, but also be community engaged. And I think that's really important from a standpoint of our, on the research end, but also on the student end. Several colleges, including the Applied Health Sciences, has really focused on understanding how we can provide community experiences for our students. I think the students are really important because there's going to come a time where we're not here.
Yeah.
And the students really have to be the group that takes on, they're that next generation of practitioners. We know that a lot of these conditions, even though there's this broad cause, that part of that intermediate risk, some of the intermediate risk factors are related to diet and nutrition. We have a dietetics program where we train practitioners to go directly out in the community, and the goal is really to make sure that they're sensitive to the community needs. So I think when we look at the health colleges specifically, a lot of the health colleges are focused on practitioner training to make sure that they're responsive.
So I'm going to ask a follow-up to that, and anybody can respond. In terms of thinking about training of the next generation, how much, I mean, this for me is about this conversation in some ways between East and West Campus, because we study racial disparities in health. Whoa, sorry, get close to that mic. And I'm wondering about how much the conversations about why race matters for health gets into the curriculum in the med school, in dietary training and health, you know, in public health. And how do we build a more robust conversation about those things, not just that it matters, but why it matters in terms of our training?
Yeah, my quick take on that is that one of the things I think we have an opportunity is to build in not just talking about social justice, but having social justice at every single level. And what I mean by that is typically we think about big data, we think about big science, but that's independent of anything that has to do with social justice. The example I gave you with North Point is really a social justice issue, right? I mean, the old saying that if you're not at the table, what, you're on the menu? But the truth of the matter is we want to actually have multiple voices at the table, and not just multiple voices of basic scientists talking basic science things, but the real transdisciplinary integration so that other voices are there to sort of at least make you aware, if not woke, but at least becoming aware of some things. And I actually think that one of the things that we should really be trying to figure out is on East-West campus, doesn't matter whether you're undergraduate, whether you're getting your PhD or junior faculty, there ought to be this thing that we are unapologetic, that at every single sort of aspect from the molecular sort of level to the community level, there is an element of social justice that's weaved in. That would be a suggestion.
I guess my one caveat to that, I would say, it's not just racism. It's racism matters, and I think that's really the manifestation of all of this is around racism. And how people, and realizing the different types of, what's happening institutionally, in terms of institutionalized racism, but also in terms of internalized racism as well, and thinking about sort of what are the impacts and people understanding that, and then thinking about sort of what are the strategies that one can do to combat that and call it out and name it.
Yeah, I think the strategies are really important because when we look at even near us, and if you think about a life course perspective, early childhood is key. Mm-hmm. So the question is, what are we doing to really strengthen systems? The knowledge is good, but the knowledge actually has to get, as we generate solutions and partnerships with the community, we want to make sure that people are supported to engage in those solutions. And so we have to engage in research, but that research becomes advocacy as well. Because if we come up with solutions that are not economically feasible for people to implement within the community, then the question is, where are we? There has to be multiple levels of solutions where community can be in leadership of those solutions. And there should come a time when you talk about community engaged research that the community is in the lead and we're in the background. Mm-hmm. So the question is how do we really move those solutions forward? And I think as been talked about before, we can't have a university, it shouldn't be such a separation between the community and the university, because if we think about students from communities of color, this place should be filled with students from these communities that we're highlighting. So when we talk about Inglewood, we talk about Roseland, Pilsen, Little Village, when we talk about those communities, what's our pipeline with those schools to ensure that those students, this is a place where students feel comfortable, they feel welcome, and they're able to gain access. Because honestly, I grew up in South Chicago, and as I mentioned, now I live between Roseland and Chatham. The goal for me, when I look at, it was people from universities that said you could go to Champaign, you could go to Cornell. It was a relationship with people that were there with me that I had a really good understanding that these doors are open. So it's not only remote, it's close-up relationships that we have with people as well.
Great. We will now open it up to your questions from the audience. Oh, we have one already? Okay. Oh, I gotta get my glasses up. How do you feel the implementation and expansion of community food systems in urban agricultural and underserved communities as a result to some of the health disparities?
Of course, I would say yes. Yes. I don't like the term food desert. I like food systems. I think food desert has sort of interesting, and some of the advocates early on had an issue with the term food desert. We have a food system that needs to be restored globally, and it just manifests itself in communities, but I really believe that the food system at the community level is really important because what do people think about you when you can't get your basic needs met? Mm-hmm. I think that says something to a child when you can't get your basic needs met. What does society think about you? Food is really at the basic, it starts in infancy. So really when we think about food systems, of course, I'm interested in food systems. I think it's really an important component about community restoration.
Okay, we've got three big questions here. I'll start with that. Okay, I'm gonna start with this one. What does it mean for the impact on inequality in health and wellness to be living under a regime that is openly white supremacist and attacking access to health care and human services?
Yeah, I think that means we have to be even more aware of ourselves. Interesting, one of the biggest challenges of being on a diverse campus and a campus that's about diversity is that sometimes we get lax in our own implicit biases. And what I mean by that is that it's easy to look at that other person and sort of say, oh, yeah. But that means we need to double down in the context of really being, I think, fairly open about what it is that we're trying to do and what we're accomplishing. I personally think that in some ways as I sort of alluded to, that I am not convinced that these may be just X number of years and they may blow over and then we'll just figure out that this was some sort of nightmare. I am prepared to I am cautiously optimistic that hopefully with the clouds and the storms that are happening now, we're planting the seeds so that once the cloud storms break, we will have some growth. I still think that we should be committed to that because the reality is, I think if we are paralyzed by what we sort of see on TV every day, I think that we're just further behind. So I've taken, as the Cubans would say, pa'lante, pa'lante, just keep moving, keep moving. Mm-hmm. I've taken the sort of approach that's what we're going to do, and that's, I think, what we're about. But it is an interesting time.
So I think as I think about the advances that have occurred, it's because of policy, and it's because of policy at the local level and largely policy at the federal level that's occurred. And we are currently under an administration that is very adamant about rolling back policy. And I think I heard something last week at a meeting where they said for every new policy, they need to dismantle 7 policies.
They dismantle 7.
I think it means we really need to be vigilant. And very clear and very articulate about the policies that we think are important, about why they're important, and really need to be pressing elected officials and others to make that happen. And where we have seen success, civil rights, disability, and others, it's because we really, in many ways, particularly sort of on the federal side, have really been adamant and in people's face. And I think that is what we need to continue to be persevere and push on that.
Although I do want to interject into this, that there's this national context and then there's a local context, right? And especially given that we have several big elections coming up, I just wanted to open up the floor in case anybody wants to talk a little bit about, because the state level politics particularly has had a huge impact on health services in the state. Do you want to?
The aldermanic matters, local politics matter, it matters. From your alderman to your, to the water person, it all matters. And actually, the more that, not just here in Chicago, the more I'm everywhere, I'm starting to figure out that people are starting to get woke again, if you will, about the fact that our activities are needed to be engaged at the community level and support of the community level to actually assist in raising voices to that. It's not just, people do have so much focused on the president, but they're forgetting the governor matters for us. And a strong governor, I've seen it, a strong governor, despite the president, can actually do wonderful things within a state. So from the governor to the state reps, the reality is I finally have gotten it all together now. I used to, in the history class, we used to talk about the different divisions of things, and we even got down to back in the councilman, and I used to say, but it matters in ways that it probably has always mattered. I'm not going to say it matters now more than it ever mattered. It has always mattered, whether we wanted to know it or not. But now it's a time really for us to get involved in a very meaningful way with our communities.
I think that's key, and I'll just mention that briefly, because we were at a high school late last week as part of a community-based organization registering youth to vote.
Come on.
And the number of youth that turn 18, youth can register right now at 17 for the election in November, and many were not aware that they needed to get registered, or they were just so busy with other things that they were not registered. And I think that's important on our college campuses and our high schools to make sure that youth are registered to vote because they have a voice, and to make sure that youth understand how important the issues are.
Yeah. I will say I was really pleased to see the email that came out last week about opportunities for voting on the campus. I think that shows great leadership on the part of you, and that was really cool to be part of that.
I'm going to start using a strategy of offering several questions at once, and you can decide which one you want to respond to, because I want to try to get as many of these. So these seem sort of related. One is about the role of public policy, which we started talking about a little bit, and how public policy can help really get at some of these root causes. And then related to this, somebody asks, without a single payer system, how can we alleviate the disparities of medical workers in facilities when doctors in affluent areas make more money than doctors in impoverished areas?
Policy.
Okay. Sure. So I think a couple of things that I'll say around policy, and actually I'm going to try to touch on. Actually, I'll do the second one first.
Okay.
I mean, one of the key things to me is really important is around access to care. And having health insurance. And so one of the last publications that I did when I was at CDC was an African American vital signs, which looked at differences in African American health by age group. And one of the things it found was that for people over the age of 65, while in the 70s, 80s, and 90s, and early 2000s, there were very large disparities. In the 2000s, those disparities essentially went away among people over 65. And I think it's not the case in younger people. And I think one of the things you have to ask yourself is what happens when people turn 65 that can lead to that. So one of the things folks get is, right, folks get Medicare, folks can get Social Security. So there are a number of very important policies that get implemented. And that gives people access to care. And that, we know that's important. However, I also think it's important that we remember in terms of health disparities that even having access to care does not mean that disparities go away. And that we need to do things within the healthcare system. We need to activate patients so that they know the appropriate questions to ask, so that there aren't barriers such as co-pays, et cetera, that limit their utilization of health care. And I think that's important to remember. So there's sort of a, yes, we need health insurance, yes, we need coverage. I'm very concerned about what potentially is going to happen with the rollback of the Affordable Care Act. But we need to remember that's not the whole story. But I think where you do see policies also, so thinking about also things like increasing the minimum age, a minimum wage can be really effective in terms of helping improve equity and making sure that those broad-based policies are enforced equally across communities.
And I think the only thing I would add is that definitely access to care, but I've now created a little nuance with that and said access to quality care.
Yeah.
Because in many of our communities where some of the doctors that you're probably talking about, they also have a lack of resources to take care of their patients. And so there is this push for really having access to quality care that I'm absolutely driven by, and I think Wayne and many of us, I mean, we're all on the same page.
I just want to add one small thing, because it's also access to food assistance.
Right.
Those policies are critical at this time, given the Farm Bill, and looking at, I mean, there's other things that have been shown, like earned income tax credit, to change household food stores. I mean, stores is household food quality. But I think really paying some attention to food assistance policy at this time is really important.
Okay, two questions here. We need to start thinking about how we can make programs for health and jobs more accessible to the people who are less fortunate. How are we going to help those who suffer from mental and physical ailments, who don't have a degree and need help? How are we going to better reach the people who need the most help? And so related to that, how would you compare Chicago's job of addressing racial inequities to other major cities in the U.S.? Is there anything that we can learn from other cities and vice versa? Dr. Wynn, I thought this might be a nice opening for you to talk about anything you learned from the Cuban delegation.
Yeah, well, the saddest part is that from around the United States, there hasn't, there are some efforts that are actually happening in Boston area. There's some different areas scattered throughout the United States, fairly small, usually focused. I think that the Cuban experience that I had actually was a redefining moment for me, because it really is going back to what, and I wouldn't call it out normally, but people like Dr. Murray and others had already thought about in the 70s. That is, you had to be connected to your community. The whole purpose of having community health centers was that it was a connectedness and a connected point and an anchor for the community to actually be involved in its own health. So what I learned from the Cubans was interesting enough, almost a look back at how you have lower resources, and in some cases, better outcomes in lower resourced areas wasn't magic, it was just involvement. Involvement and engagement of the community in their own health, involvement and engagement of the system in a real public health way in which there was this partnership that actually existed. And believe it or not, people don't want to talk about data, but when you get in a cab in Havana, you have a taxi cab driver who can tell you about the infant mortality rate in different provinces. And so this conversation that, well, our people are so, no, they're not so, no. Our people in every community, I think, will surprise us about what they know and actually put us to shame in how little we know about those communities. So what I have learned is that in an era of high tech, I like to push this concept of high touch as well. And that's where I think that implementation science and the implementation of policies and our ability to sort of lead the country, and I don't say that, it's not hubris. I'm not trying to say that to just be provocative. I really do think we have an opportunity here because we have the right type of people here to figure out in the 20th century, how do we re-engage, reconnect, because that is actually going to be some of the secret sauce of improving health in the 21st century as well.
Other thoughts about things we should learn about from other cities?
So I think I'll give an example. I used to be part of a program called REACH, which stands for Racial and Ethnic Approaches to Community Health. Chicago was one of the cities that was funded. It was started under Dr. Satcher when he was Surgeon General. And one of the communities was the Bronx. So they were initially very focused on delivery of health care. And doing a better job of optimizing health care in their community, and worked with a number of federally qualified health centers to do that. But they realized soon that there was something, the health centers realized there was something broader that they wanted to do. And so they were the ones that pushed the New York City schools to provide much healthier food in the schools. But again, it was moving from a health system, moving from just delivery of health care to thinking about what they could do in the broader community. They're now doing work around combating racism in the community. But again, it was sort of a nice example of how a health system had evolved over time and really got out front in terms of a number of policies.
I also was going to say that I think that we should be the leaders in thinking about where the new jobs are. Particularly for our communities. As big data gets bigger, we still are in this concept of, well, we have a 2-year degree and that's okay, but data's going to get more complicated, it's going to get bigger, we need more people. Shouldn't we be on the leading edge of figuring out how to develop that workforce? And so in some ways, I think as a public institution, we are well poised to be able to look at what's about to happen. They used to say about Fidel Castro, he would go into the future and then come back. Right? And so in some ways, I think that we have the opportunity to look at the future and come back and start designing, again, as a public school, as an elevator school, and unapologetic for that. I think we have ways of actually looking at the workforce, working with not only within community colleges and high schools, but start developing what that workforce is going to look like, to give other people opportunities in those areas that we're not thinking about now. That's my hope and my dream, that we will be creating that and have curriculums that actually look like that in the future of actually getting out there and doing some amazing things.
Definitely.
All right, I think Dr. Odoms-Young, this one might be starting with you at least. The topic of early childhood has been mentioned as an important intervention point at you. How can the UIC community come together around early childhood across colleges, housing, health, education, et cetera?
I think that has to just be an initiative that comes from the top. I think if you look at some of the, like Resilience is a film that has recently come out, similar to Unnatural Causes, when you look at the role of early childhood, and then of course the issue of trauma, and I think those initiatives, if we could really convene around some issue university-wide. I think the thing that happens with early childhood, because we work both in the city and we also work downstate. A lot of the focus of my work is WIC. So really, when you look at some of the issues that happen, it's not just Chicago, it's across our entire state, and of course our entire nation. But if we look at the University of Illinois as a system, there's really some things that we could come together when you look at research and training. Really, if you take the life course perspective, if we don't address pregnancy and early childhood, coming in when somebody is, you know, an adult or even in adolescence is good, but we really have to look at that early life. It's critical from both a psychosocial and mental health standpoint, because women in pregnancy that face trauma, we know that it can impact not only your mental health, but also epigenetics, how genes are turned on and off, issues, brain development and architecture. So I think that it is very, very important that we, as a university, look at early childhood and what we can do together.
Okay, this sort of builds on the question we were talking about a minute ago. As a health science student that is not taught a lot about race and racism, how do I advocate for the education or educate myself other than attending talks like this?
I guess there are a couple of things that I would suggest you think about. So one would be talking with your leadership about your needs and what you want. I will tell you, one of the things that I've done that I'm relatively new is I have office hours every Thursday from 2 to 4. And so, I would encourage folks, to come and talk, talk with deans, talk with department chairs, et cetera, but have a conversation about what you think you need in terms of your curriculum needs, and be, I would say, be persistent and be vocal about that. Because I do think there are some really cool opportunities that we can push forward.
And I think that the conversations happen more frequently here than at any of my other previous universities I was affiliated with. And so I think being connected to that is actually really important, because, the truth of the matter is it is a major issue. It's a major issue in Chicago. It's a major issue that, if we're not careful with, actually has impact here on this campus. And so, but one of the things I think I'm actually happy about is the student organizations are really active, which I really like and wish they can get even more active. But our faculty are receptive to those types of conversations. And I think that I've had more opportunities to see on the East and West campuses the addressing of those issues than I have in my entire career. But we need more.
Yeah, and I think even asking the question at something like this is pushing the envelope as far as needs. Because a lot of times I know we put responsibility on students to push, and I think they need to push, but that is something that I think we need to hear across the board as both faculty and administration, because generally when you look at faculty in some of the health colleges, the idea of diversity, the idea, and kind of moving beyond, I'm interested in racism, but also when we look at LGBTQIA, bringing those issues of sexual minority, bringing the issue of disability, all of these things should be at the forefront when we think about faculty and faculty training. Because some of it is students have to push, but also the issues come in the classroom because faculty get trained in teaching those issues. And I know some folks, if they have not been trained, may not feel comfortable in bridging those issues. And honestly, from the experience of both as a student and a faculty, sometimes when folks are not trained, you don't want them bridging those issues because they're not going to bridge them with the level of sensitivity that's needed. So I think from the standpoint of an institution, we need to look at what kind of training is available to make sure that faculty bring those issues into their classroom as a requirement. Not that we want to, I'm a faculty member, not that we want to force people to teach certain things, but we have to make sure that, because it's the wave of the future, if we're going to make sure our science is right and up front, we need to make sure that faculty have a good understanding of that and that they get trained to do so.
I'm going to actually make a plug also for an additional racial issue, which affects me every day, to be honest with you, sometimes big, sometimes small. But I'm going to actually make a pitch also to not lose sight of gender issues as well. I think that we're in an era that as we look and hopes for my daughter in the context of her ability to have leadership in certain areas and being able to sort of be able to thrive and to think and to be part of engineering and all these other things. Again, what was interesting about North Point, that North Point incident had not one, it was all Caucasian men, the whole crew. Not even one engineering, what are you sort of saying, that women can't be actually, you know, computer, so forget all of, I think it's an and conversation. I've been teaching, I mean, I know I sound like Jesse Jackson and Rainbow Coalition, but that's all right. But I honestly believe that conceptually, we have to make sure that we talk about race and other things and have these and conversations, because I don't want to take our eye off of the issue around gender issues as well, which I think are important. And again, we can lead the country, I think, in behaviors that sort of say, listen, you know, we're not braggadocious, we're not U of M. One thing I liked about University of Michigan, everything they do, they were like, see, Michigan.
Yeah.
Number one, Harvard, you know, actually, I really like this place because we're doing great things. In fact, we're doing innovative things. We're not doing the sort of running around and taking just credit for it, but we are the place where I think many of these issues are getting hashed out. Yeah. And I would really like for us, again, as a public institution, to sort of think about race, think about gender and all these other things, because I think there's room and capacity for us to do that.
Yes. I want to just also add to this last conversation about thinking pedagogically and what happens in our classrooms, that very naive, there was a moment actually when I was teaching at Emory for a minute, and everybody there was pre-health as far as I could tell, when I was teaching an intro race class in sociology, and it occurred to me in a moment when we were having a perfectly developmentally appropriate conversation, but one which highlighted the fact that most of the students were operating with all the kind of rampant racial mythologies that fill our society, but that would be dangerous within any, well, that are dangerous in many spaces, but particularly dangerous in a patient room, you know, and when people are projecting those mythologies onto people's bodies and all kinds of things. And I realized that these all people were about to go to med school and nursing school and all these places. And how much work we have to do still on really directly confronting all of those kinds of things in our practice and in our teaching. And I don't know enough about the curriculum across the health colleges, but I do regularly hear from students who say, we don't ever get to have this conversation, how can we have this conversation more? And I think there's a real space in sort of picking up on your saying for UIC to take a more, a bigger role in kind of setting a new path for thinking about this stuff curricularly, particularly in training of the health professions. I mean, I thought about it more in terms of, and seen it more in conversations about training of teachers, but I think it's a lot of it's sort of the same conversation is how do you get people to be in a position where they're capable, trained in, ready to have conversations about how to help everybody thrive in these different contexts. Okay. These are sort of related, so I'll pose them at once. Considering the conversation seems to occur among like-minded individuals, what are your thoughts about how to engage colleagues to participate rather than defer efforts to those few social justice advocates? So how do we get everybody involved in this? And sort of related, solving these issues involving health disparities seems to require true interdisciplinary action. How do you think UIC colleges and institutes can overcome the enshrined traditional silos of academia, and how do we get more collaboration going on across different buildings?
So, you know, around the 7 health colleges, you know, one of the things that is the rage right now is interprofessional education. And so you know, we're going to have, I think in a couple of weeks or so, what we call IPE Day, where we get students from all the different colleges all coming together and so, you know, and I think we're focused, right, I think the next one's going to be on opioids, I think, if I'm not mistaken. But we should think about the opportunity that provides us to in fact have a very broad conversation about health disparities and how we could frame some of that and really to address that. And I think we could think about, you know, across the college. So I think that's one thing. But there might be other opportunities where East and West could come together and students could think about, and faculty together could think about sort of some sort of brain trust, where think about sort of potential strategies around addressing these issues. That could be some cool conversations.
I think we're actually, the funny part about that is we are underway right now with what I'm going to I used to call the grand experiment, but I've just moved it to the big idea. And the big idea is, how do we move people who are traditionally not actually so focused on these issues and get them involved in the conversation and actually get them moving towards the same thing? To do that, I think you need essentially in my mind, in this case, a big effort. The big effort is not just changing the campus minds around basic scientists, our clinical people in the context around health disparities, but actually, and I say this with all the humility that I really mean this coming from, but we are now making the big idea of how to change the country so the conversations are starting. What do I mean? Our effort in trying to be an NCI designated cancer center, the first of its kind, that is unapologetic about its focus on disparities, which doesn't always mean race, right? But disparities. But certainly we're unapologetic about the racial issues of life expectancy. To me, is not only a big idea, but sitting in that room, I had probably one of the proudest U of I moments I ever had, recognizing that there is no one else who actually is saying it. And when they say it sheepishly. It would be great if we, right? We've just got rid of the great. We're like, this is what we're doing, and it's going to take the effort from the East and the West Side campus to sort of do this. I'm really proud, again, I don't say this lightly, that we have an opportunity. Now, what we do with that opportunity is on us, but we finally have an opportunity to sort of change the conversation, because once that actually happens, and you say, well, there's this elite club of NCI designated cancer centers, and, well, wait a minute, one's at UIC? To be at the table, to be the consistent voice, to be unapologetic that, yes, we're doing this, and yes, we hopefully will be the role model or the models for others to sort of join, if not at least push people and push the envelope, is something about how to get others on board. And so I think that we're finally trying to figure out how to do that. I'm really happy, but I think that I only use the NCI designation as an example. There are probably many other things that we could be doing across campus, East, West campus, different things to sort of get together to do exactly the same thing. But that was one just concrete example of how we think we're going to change the needle on the conversation, so that 10 years from now, it is not unusual. And people say hey, you know what, I walked in a room once and someone sort of said, hey, who, Dr. Wynn? Oh, are you in the right meeting? And I said, the Cancer Center's director meeting? He was like, yeah. I was like, yeah, right? It was surprising for him, and he almost said, I have never seen a black director, and I said, it's okay. But I think that we are, again, slowly but surely, by concrete efforts of communication and getting intra-colleges, intra-departments together to sort of, let's do the big idea. And I think that we are doing it. So we'll keep you posted.
You know, I have really two comments to that. I think one is history. We can't really forget that these things happen every so often that people think, okay, we need to come around something. And if you think about universities and the issues that have emerged over periods of time, you know, I think it's really important to think about what has worked. We can't just be starting with a blank slate. One of the things that I know traditionally has worked is funding. Funding that brings scientists together across different disciplines. And I think the other thing is that at the top, if there's some efforts, I think Amanda spoke to this, all it takes is planning. Do we have a task force of people to really look at the curriculum and figure out how do we have, because the way we get credit and tenure and these things sometimes can be barriers. So why can't we have a joint class that's taught that may be housed in IRRPP, that's taught against a health, you know, and a social science. You know, when you think about the medical school curriculum and you think about the dental school curriculum, we're very siloed in how we teach our curriculum and what's required for students. Part of that is really looking at the structure and changing some of the structure of that. And we need a task force, probably campus-wide, to address that.
Well, this might be a good last question then. As leaders of color and individuals who work on these issues, what can leadership at UIC to continue to support you to do this work? We have about a minute left, so thoughts?
Well, I really like your comment about the incentives, and I mean, I think that's number one. I think number two, creating safe places for us to have these conversations, to me, is important as well as we think about this. And I do think also opportunities for faculty, student, and staff to be engaged in the policy arena is really important. Sort of would be my last thing that I will say. You know, I will say that I am particularly excited about what has been able to happen over the last couple of years around policy changes around tax reform, where we had graduate students really mobilize to combat some of the detrimental parts that were part of the initial aspects of tax reform. And that, to me, shows that when folks come together, they can really have impact. And I think the same can be true around racial and ethnic health disparities, because I do think us all, you all as young people, collectively mobilizing can have a huge amount of impact.
I think that's important, too, that we do our own policy analysis. And do we really have equity in all policies? Yeah. As a university, a lot of times we talk about health in all policies nationally, and people have pushed for this idea of equity in all policies. When you look at institutional policy, we can really be the leader in that. We probably already have places where we have equity in policies. And so when you talk about, you know, student training or research, if we are, you know, the conversation is moving forward, I think that next step is really to look at our policies. Because the thing that kills progress generally is, one thing is we've always done it this way. Second is that we don't have the resources. So generally, when you look at killing progress, people say, well, we don't have the money to do that. Or they say, we've always done things this way. So I think the key is really looking at things like policies for faculty, policies for student training, and make sure that we have that equity conversation in those policies.
Dr. Wynn, any last thoughts?
In an effort of brevity, I'm going to say that was well said, so I have nothing to say.
Yes. Thank you, everybody, for joining us here today. I will say I very much appreciate the sentiment of unapologetically embracing our values and being proud of what UIC is and can do. So I appreciate that. Thanks very much.
Thank you.
Thank you. Oh, yeah, we'll take it.